webcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon. Today is August 18th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Personal Supports and Electronic Visit Verification Implementation webcast. Our presenters for today are Jesse Song, who's with Medicaid Provider Services, Ian Collins, A&M Consultant, Rhonda Workman, Director of Federal Programs, Chioma Ani, LTSS Program Manager, Valerie Roddy, Director of Fiscal Services and Operations. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There is one option for listening to the webinar, and that's by computer. There's a handout for the webinar, and you can find it in the handout section in the panel to your right. They can also be emailed. We will be recording the webinar. Questions can be typed in the question box in the webinar panel, and we will answer them at the end. And so now I'd like to introduce Chioma Ani.
Thank you, Donna. Good afternoon, everyone. We can move on to the next slide. So just a quick run through of our agenda for today. We will be doing an introduction to electronic visit verification. We will take some time to talk through DDA's implementation approach and the strategies around that. We will also focus in on person-centered planning strategy to make sure that we are prepared over the next few months. We will discuss personal supports versus personal supports enhanced as services, the communications around electronic visit verification as we gear up for the next few months, and any additional information, resources, and reminders for this group overall. Next slide, please. So moving forward to introduce us to electronic visit verification and what that means, I will turn it over to Jesse Song with Medicaid Provider Services.
All right, thank you, Chioma. Everyone, I'll be discussing EVV today. Next slide, please. So we'll start off with the why. The reason why we are pursuing EVV is because of a federal mandate, the 21st Century Cures Act. So that requires Maryland to verify for 6 different factors for personal support services. And so these are the 6 different factors, but most importantly, it collects who the person receiving the services is, the location of the service, as well as the individual providing service, or the DSP. All right, next slide, please. So what is EVV? Well, EVV is for short. It's for any technology that verifies that services are delivered at the right time, to the right place, and to the right person. And this will be both a requirement for traditional as well as self-directed services. So in-home support assurance system, or ISAS, is the tool that Maryland is using to implement EVV, and it is a phone-based system. So any direct support professionals or DSPs will be using this at the beginning and at the end of the service, using one or two methods, which I'll get into in just a second. Next slide, please. So there are many benefits for EVV. For the person, it helps them ensure that they are receiving the authorized services. And this can also improve quality of services because it helps the DSP's activities become more transparent to everybody. For the benefit for DDA, it provides data on when the DSPs start and stop services, and also reduces the likelihood of billing errors and potential fraud. And it's a way to help hold providers accountable. And most importantly, it helps DDA become in compliance with the 21st Century Cures Act. For the providers, it will gather all this information in an online system. LTSS Maryland. It's a place where all the provider administrators can log in and see their DSP's activities, and it is all in real time. So, and there's reporting tools in place, and it automates all of the billings as well. So by recording when the DSPs start and stop, it will reduce the likelihood of billing errors and fraud. All right, next slide, please. So the system that's Maryland's using to implement EVV is ISAS, and is a phone-based electronic billing system. And this means that any traditional service providers or the DSPs will call into ISAS, which is a toll-free number. They will call into that to clock in, and they will call at the end of the shift to clock out. So the ISAS system verifies who the provider is through two key data points. One is through the provider Medicaid number, as well as the DSP's social security number. So with these two items, they are able to verify who the DSP is. The ISAS system will verify who the person receiving services is through two items, either the telephone or the OTP serial number. And I'll get into that in just a second. And the last item, the ISAS system will also verify that the service is authorized according to the person-centered plans. It will also check against the PCP's monthly units as well. So all this will interact in the back end with the LTSS Maryland system. So when the DSP calls in, that final check is not done then, but it will be done on the back end. All right, next slide, please. So ISAS will verify who the person is through two different methods. The first and most common method is when the DSP calls in using the participant's personal landline or cell phone. So when the DSP calls in through one of these numbers that's listed in LTS Maryland's participant profile, the ISAS system will know who the person is. So that way the DSP doesn't need to enter in any additional information. They just clock in and the system will know who the person is. And it's important to note that that phone number must belong to that participant. The second method is an alternative method if the first is not available or reliable, and that's through a small token called a one-time password or OTP device. So this usually happens if the DSP needs to call in through a phone number that is not in the LTSS Maryland's client profile. So in that case, the DSP will need either the client's 11-digit medical assistance number, or they can also use the 9-digit OTP serial code number. And we'll show this on the very next slide. All right, next slide, please. So this here is the one-time password token. So you see it on the picture on the left. So this device will generate a random 6-digit timestamp. And that's what is needed whenever the DSP wants to clock in or clock out. So, and in cases where the participant does not have a 11-digit MA number, the DSP can use the 9-digit serial number, which is located on the back. So on this token, there's a 6-digit number that changes every minute on the front, but on the back is just a 9-digit serial number, and that will remain static. And that's what the DSPs can use to help identify the participant. So there are 4 scenarios where the OTP is assigned. So the OTPs are issued if the person does not have a reliable phone number, phone that the DSP can use. Second scenario is if more than one person in the household shares the same phone number, then in that case, then the OTP will be needed because the LTSS system will not know who that person is. So the system needs a unique phone number. And this third case is if a person often receives personal support out in the community, then in that case, an OTP token would be needed. And the fourth and final case would be if the participant does not have a 11-digit Medicaid number. So these are all the state-funded participants. In that case, an OTP is needed because they'll need that 9-digit OTP serial number to help identify the participant. All right, next slide, please. So just a quick summary of how the OTP is assigned in LTSS Maryland. So we, at the Medicaid Provider Services, we order the OTP tokens and we have these sent out to the CCSs. So once the CCS receives these, they will then assign these to individual persons. And then they will also be in charge of distributing those tokens directly to the persons. And if there are any devices that break over time, like for example, run out of batteries, they can be returned back to the CCSs. And the CCSs will also be the ones coordinating if there's like a lost or broken token so that the participants can get a new token. Just important note, the token should stay with the participant at all times, which means the DSPs cannot take these home with them, so they must remain with the participant. And if there's any issues with the devices, they should be coordinated between the CCSs as well as the clients themselves. All right, next slide, please.
Good afternoon, everyone. My name is Ian Collins, and we will next talk through the implementation approach by the DDA. So based on data and input from all DDA stakeholders, the DDA has made the decision to use a regional implementation approach for the EVV Go Live process. So this approach will provide the DDA and its partners the most time to ensure that all program participants have PCPs that are approved, effective, and ready for billing prior to the January 1st, 2021 CARES Act deadline. So if you take a look at the table on the slide, this will walk us through what the implementation will actually look like. So we are going to have 3 specific provider go live dates. The Eastern and Western regions, providers that operate solely in the Eastern and Western regions will go live on October 1st, 2020. Southern Maryland region will go live on November 1st, 2020. And then the Central region providers will go live on December 1st, 2020. Providers who support people in personal support services in multiple regions will transition to EVV at the latest date for the regions in which they operate. And we're going to go ahead and take a look at what that actually looks like in practice in the next slide. So this slide looks at what the impact of the regional implementation approach looks like on a provider level and below on an individual participant level. So looking first at the top section, the top part above the dotted line, we're focused just on providers. So the leftmost table there looks at the number of providers that operate in each region. So providers that operate in multiple regions will appear multiple times. So for instance, if I'm provider C and I operate in Eastern, Western, and Southern, I appear 3 times in that first table on the top left. The table on the top right looks at the distribution of when providers will actually go live following the DDA strategy. And so that's why the left side and the right side tables have different counts of total providers. Said differently, the total on the left includes duplicate counts, while the total on the right is a unique count of providers. So to give an example, just because that sort of helps me think about this, right? Let's assume a provider A, provides services to participants in 3 regions, in the Eastern Shore, the Southern, and Central regions. Provider A would go live in LTSS Maryland billing for PS services on the latest date possible, which in this instance would be with the Central region, which would happen on December 1st. Alternatively, another example, let's assume provider B operates in the Eastern Shore and Southern region. Provider B would go live again with the latest date possible, which in this instance would be the Southern region on 11/1. And if you had an example of a provider, let's say provider C only operates in the Eastern region, Eastern Shore region, that provider would go live on 10/1. So the participant section below provides very similar information. The left table shows the distribution of assigned regions based on where individuals live. And the table in the bottom right shows the distribution of how people will go live based on when their provider goes live. So an easy way to think of it is participants will go live when their provider goes live. So for example, if we think back to our example of provider A, as a refresher, provider A provides services in the Eastern Shore, the Southern regions, and the Central regions. An individual that's receiving services from provider A, regardless of where they live in the state, would roll in at the latest date for that provider, which in this instance, again, would be December 1st with the Central region. And so the pattern would continue to follow along that sort of same logic. Next slide, please.
Hi, this is Rhonda Workman, and now we're going to start to talk about the person-centered planning strategy. So to ensure that all our person-centered plans currently reflect the chosen service provider and the needed service units, our plan is to review all person-centered plans for people receiving personal supports. The DDA will be prioritizing and sharing lists with the coordinators of community services and providers so that we can coordinate efforts based on the information that Ian just shared. We plan to share and implement a new detailed service authorization tool that can be used to help to establish the units that are noted in the PCP detailed service authorization section. We also have established regional office teams that will be supporting the effort in the review of all the person-centered plans for people and personal supports so that we can have them reviewed and approved within 20 days. Next slide, please. The new detailed service authorization tool that I mentioned is meant to assist teams with identifying the estimating monthly service units that are needed in the PCP detailed service authorization section. We have heard from CCS agencies who have developed similar tools and worked with some of the pilot providers. We've gathered these tools, and from these tools we'll be establishing one standard. The new tool will include the provider's Medicaid number to assist the CCS with the identification and selection of the provider in the detailed service authorization section and to help minimize errors. We know and recognize that some of our providers may have more than one Medicaid number due to the different services that they're providing. And to ensure that we are identifying the correct provider, we feel by adding this information to a tool will help to identify the provider when the detailed service authorization section is completed in LTSS. Next slide, please. So with this new tool, let's talk about the process to have this tool completed, reviewed, and entered into LTSS. This process involves the provider completing this new detailed service authorization tool. They would then be sharing it with the CCS, who then would confirm the units that the provider has proposed with the person. The CCS would then enter units into the PCP detailed service authorization section. The CCS would send the service referral to the provider as current practice. The provider has the ability to accept, or what we're asking is call the CCS if there's any concerns with it, and then the CCS would submit the person-centered plan to the regional office. It's critical in order for this process to work and our efforts to review all person-centered plans that have personal supports to make sure the person has the appropriate services and provider identified, that it's going to take critical coordination between the CCS and the providers. We're hoping with the completion of this new detailed service authorization tool by the provider, it will help to streamline the information for entry into the detailed service authorization section. And then by having the CCS confirm that the units will meet the person's preferences and needs, that will help to support our person-centered planning. We hope to be able to share this information with you soon this week related to this tool. And as I mentioned, when the provider receives the service referral from the CCS, it is important for them to review that, and what we hope they will be able to accept it based on having submitted the detailed service authorization tool to the CCS. But in the event that maybe there was an error or glitch in the entry, we ask that providers call the CCS to share the concerns so that it can be corrected and fixed immediately. If needed, the CCS can revise the detailed service authorization section and resend the service referral to the provider. We're also asking that the CCS, when they submit the plan to the regional office, that they first upload the new detailed service authorization tool in the PCP documentation section so that it can be included with the record. Next slide, please. So given this new process, we wanted to make sure and share with you that there's a variety of supports available to help in case a need arises. The regional office provider relation director should be contacted if the personal support provider's Medicaid number is not visible in LTSS Maryland. If the provider does not accept the service referral in 5 days, the option is removed and the CCS will need to send a new service referral. But again, we're asking that you call the CCS to alert them to any concerns. The LTSS Maryland Help Desk tickets should be submitted for system issues via the feedback tab in LTSS Maryland. The regional office CCS squad should be contacted for any assistance with team disagreements and conflicts that cannot be resolved. In addition, we plan to coordinate for the regional offices to conduct weekly calls to address concerns and challenges with the CCS and providers. Next slide, please. It's important to note that in LTSS, for personal supports, there are 2 service options available. So in the LTSS PCP detailed service authorization, there are drop-down options for 1, personal supports, or 2, personal supports enhanced. An enhanced rate for personal supports is available when a person has an approved behavior plan or person has a health risk screening tool of a 4 or higher. So to access this enhanced rate, personal supports enhanced service must be selected in the detailed service authorization section instead of the standard personal support services. It's important to ensure that the health risk screening tool and the approved behavior plan as applicable are current and included in the PCP prior to submission to assist with the regional office service authorization. In addition, considerations for transportation support services, which may have already been included in the PCP supporting personal support services, may need to be ended as the new LTSS personal support service and rate includes the component of transportation. Next slide, please. As I mentioned, it's really important to have the health risk screening tool included in it, and also to look at the transportation services if they need to be continued if they're supporting personal supports. Next slide, please.
So as Rhonda stated above, to ensure that PCPs correctly reflect the chosen service provider, the correct service, and the needed service units, all PCPs for participants receiving personal supports will be reviewed by the DDA. And to streamline a review process and prioritize PCPs requiring potentially the most work, the DDA has implemented a targeted PCP tracker that triages PCPs for all individuals receiving personal supports. And really the goal of implementing this tracker is to minimize or eliminate disruptions in service delivery and billing before and following the go live dates for each region. So the DDA tracker will also provide our internal DDA team with the type of data on where all personal support PCPs are in the approval process. While this tracker is now in use It is still a bit premature to show what that data is looking like at this point, but the DDA will, as the tracker continues to be filled out, share data with our stakeholders on the progress being made on the PCP review process for all individuals with personal supports. And, just as a final reminder for those on the call, it's really important to focus on how we can all support this process. We're encouraging all providers and CCS agencies to look at your available data, to understand how many PCPs for your respective agencies need to be addressed prior to specific go-live dates, and to begin working with your teams and the people that you partner with most closely to move those PCPs through the system. Next slide, please. And before we get to communications, there's one final component related to PCPs and EVV readiness our team wanted to touch on. For some time now, the DDA team and the provider community have been working towards getting all providers enrolled in ePrep so that providers can be added to PCPs and so that they can properly bill in the new LTSS Maryland system. The DDA is currently working to close out the final 4 personal supports providers. You can see that we've got 141 out of 145 enrolled. And that will finalize and complete the provider site-based enrollment process for personal supports providers. You can see that the community has made a lot of progress since January 2020, and we're really grateful to all the work that's gone into making that possible. The DDA has certainly prioritized these final 4 providers, and we expect them to be enrolled by the end of next week. Next slide, please.
Hi, so this is Chioma, and I will walk us through communications and training. Next slide, please. So over the next number of months, in coordination for this effort, DDA will be sending out multiple communications via multiple approaches. All our communications on this effort will be coordinated with Medicaid provider services to make sure that you are receiving the information that is both DDA centered, as well as information that needs to be shared from Medicaid perspective as well. We have identified our stakeholders here, primarily as people in services and their families who are in personal supports, so they can be involved and informed on what is upcoming and any potential changes to processes that they may have in place for when they receive services. Communications will also be distributed to providers at various provider agencies and CCSs who coordinate the services for these individuals across the board. There will be multiple approaches to those communications, so we encourage you to look out for all of these. We are in the process of finalizing a dedicated EVV webpage on the DDA's webpage. There will be at-a-glance documents that are shared. There will be specific guidance documents that are shared around particular processes. There will be policies that are tied to each aspect of EVV that will be distributed as well. We also will continue to send out LTSS bulletins that are specific to LTSS functionality in the system. We will be hosting webinars and interactive remote sessions for people in services and their families to allow opportunities for questions and greater understanding of the process and where what is required with EVV. We are also in the process of developing a toolkit for DSP training for provider agencies, where we would encourage you to share these with your DSPs to help answer the questions that they may have, in addition to whatever internal policies and processes that you are putting in place as providers. Next slide, please. So to talk about the training aspect on that for provider agencies who are going to be using the clock in, clock out process. We are working on finalizing training materials. Training will be delivered via an online approach over the next number of months. Training for providers and the provider portal billing will begin in September of 2020 and will run through December of 2020. Again, this will be a remote session due to current restraints, and it will cover the LTSS Maryland EVV billing functionality. We are separating this training for EVV functionality away from other billing functionality in LTSS for non-EVV services so that we can have a more targeted and focused approach over the next number of months. In combination with Medicaid, we will be putting together materials for DSP training on the ISAS system. As Jesse presented earlier, there will be webinars as well as printed materials that run through the process of using the ISAS system for clock in and clock out, and any additional questions that may be helpful for DSP to have answered around that process. This training would also be included in the provider portal billing training, so that provider agency billing teams or administrative teams are aware of what to expect out of their DSPs. DDA is also working with Medicaid and our technical supports to create what we are calling a practice EVV line. This practice EVV line will be live in September of 2020. And what it will do is allow providers, direct support professionals to get used to the clock in, clock out process. In the ability to use the practice EVV line, DSPs would be able to clock in when they go to a person's home or meet with an individual to provide the personal support services, and clock out subsequently after the service has been completed. This will allow provider agency leadership to encourage and the opportunity for direct support professionals to get used to the system. Next slide, please.
So we're also working on and going to be issuing a number of policies related to personal supports and EVV. So Medicaid provider services will be sharing ISAS policies, and the DDA will be issuing personal supports policy, a policy related to billing, and a policy related to transportation. We are going to be issuing our policies using a platform called PolicyStat. PolicyStat is an online platform that we're going to be able to share publicly with all of you our different policies. We'll be launching it this week and share additional information during Friday's webinar in terms of the different components and how to access. Next slide, please. You can go to the next slide too, Donna. Thank you.
So to walk us through some of the things that we have to consider over the next number of months in preparation for EVV, we'll start with turning on or talking about the system functionality. So currently in LTSS, providers who are providers of personal support are able to walk through the process, as Rhonda went through earlier, of receiving a service acceptance for someone in personal supports, accepting that, and subsequently having the regional office approve those PCPs. So that service is then activated or is then live for that person in the system. In order to allow provider agencies to be able to bill, DDA is going to turn on the system functionality that allows you all as provider agencies to be able to do that. We will be turning on this system functionality based on regional implementation date and by the specific service, which in this case is personal supports only, including personal supports enhanced. This will be live as of the first of the month in order for billing to properly process for the rest of the month. So as an example, if ABC agency is activated for personal supports on November 1st of 2020, then ABC agency would be able to bill for all the people that their agency serves receiving personal supports starting November 1st of 2020. So Ian shared some of this information earlier. I just wanted to make it clear that as a provider agency, you will be going live for all the people that you provide personal supports to on the same date. Next slide, please. In order to continue to support that, as was mentioned, we will be working with Medicaid provider services to distribute the OTPs as well. Jesse went through the process of how this will occur in the system when the OTPs are assigned by batches to CCS agencies and then distributed to the CCS agencies. That will begin in late August. Subsequently, CCS agencies will be able to distribute to the participants based on their current business model and policies. Next slide, please.
So we wanted to share some CCS reminders. First, coordination with providers is essential. In order for a person-centered plan to be authorized by the DDA, it must meet requirements noted in the PCP checklist that we have shared with you. In addition, CCS supervisors are to review and sign off on PCPs prior to submission to ensure the quality of the PCP. Submission of the PCP with all service provider acceptance will decrease the need to submit future revised PCPs. In other words, you can use the new detailed service authorization tool to get the units and services from all the providers and have that completed and facilitate the service referral process. The regional office CCS squad is available to answer questions and provide assistance as you need. Next slide, please. So this slide is for provider reminders. And so again, first, coordination with CCS is essential. In order to provide and bill for services, your agency must be listed on the approved PCP with the appropriate Medicaid number. In order to receive and accept personal support services referrals, it is important to make sure that you have set up appropriate provider portal user roles for your staff. Regional office provider relations staff are available to answer questions and provide assistance. Remember, if you have more than one Medicaid provider number, you want to make sure that you indicate the correct number associated with personal supports in the new detailed service authorization tool. Next slide, please.
To help facilitate the process, as Rhonda just mentioned, for service acceptance in LTSS Maryland, we wanted to talk through the types of user roles that currently exist for provider users in the system. So the admin provider role. The admin provider role is typically agency leadership that creates and manages staff roles in the system, is able to accept services, subsequently bill for services, and can complete all leadership agency functions. The program director role allows the individual assigned that role to accept service referrals on behalf of their agency and to view general participant information and run reports on participant information as well. The program staff role allows the individual assigned that role to review service referral requests and view participants' information in the system. Program staff can indicate when they have completed a review of a specific service referral request so that the program director or admin provider can make the final decision on accepting or declining that request. The billing provider role is a role that allows the individual assigned that role to be able to enter billing for services that are rendered and to view participants' information in that process. The staff provider role is a role specifically and only for the direct support professional. This role assigned in the system can complete clock in and clock out processes with EVV for personal supports and personal supports enhanced. So with that being said, we want to remind provider agencies to ensure that your DSPs are entered into LTSS provider portal and that they are assigned the staff provider role in the system. This is to allow them to be able to complete the clock in and clock out with EVV. DDA recommends that all providers begin now to enter and register DSP staff into the system and allow them to use the ICS system in the next couple of months. Staff provider roles are the only roles that do not expire in the system. Only the admin provider at the agency can make updates to add or delete any staff provider or DSP roles in the system. If you would like some additional information with regards to how to do that, those two links are listed at the bottom, reference for the LTSS Maryland training video. You may follow those links to access some additional information on how to set up your staff provider roles in the system. Next slide.
Chioma or Jesse, would you like to share this slide?
Sure, I can walk through that. So the EVV roles that are required for a personal supports provider agency, the responsibilities include managing your DSP staff in the LTSS provider portal system, ensuring your DSPs are trained to provide services and to use ISAS, reviewing and ensuring the accuracy of services that are entered into the system, whether that is via the clock in, clock out system by your DSP, or any additional updates that you as provider agency administrators make to the system in LTSS provider portal. It is also an agency's responsibility to assist with the exception resolution and manual entries process. Direct support professionals are expected to be able to provide the direct supports of personal supports to the participant, will be expected to use the ISAS system to clock in and out, and direct support professionals will be required to report any issues with clocking in, including any missed or forgotten times, to their agency administrators. Subsequently, agency administrators, as was mentioned earlier, are able to log into LTSS provider portal to make any updates to the missed clocked in or clock out times. Next slide, please. And Medicaid's ISAS team will be helping to support this process by being the point of contact for any issues with the ISAS system. Any policy questions, billing or payment issues, or general system process questions can be reached out to ISAS team at the contact information that is listed below. Email and phone number is provided and is shared with this handout for any additional questions that may surround the ISAS process. Next slide, please.
So we wanted to touch on provider payments and billing. So to ensure timely payments, providers will need to be set up for electronic fund transfers. This way your money can be transferred to you electronically. You don't have to wait for paper checks. The instructions for this, if you are not already set up, and most, if not many, of our providers already are, but it's a good idea to check and make sure that your agency is already registered in the system. But there is a link in this slide and in this document where you can see the information so that you can set up the electronic fund transfer in case it is not already done for your agency. Next slide. Okay. So personal support providers, like all providers, receive the first quarter payment in early July. Providers will also receive an interim payment in about 2 or 3 weeks that will cover the 4% provider rate increase that was not included in the first quarterly payment. The next advance will be the second quarterly payment that will be issued on or before October the 5th. As we think about it, providers will begin using ISAS on October 1st, November 1st, and December 1st, depending on the region in which they provide services. Once they begin using the ISAS system, then they will also be able to begin weekly billing after the go live date. Meanwhile, however, DDA will issue the third quarter payment in January to ensure that providers have sufficient cash flow during this transition. The funding will be reconciled during the annual cost report process. Next slide.
In order to be able to support this process overall, we are tracking to various aspects of system functionality in LTSS. With that, we are working with our developer to track usage and speed in various parts of the system due to the feedback that we've received. And we are working on identifying and fixing heavy traffic areas to make the process operate a little bit more smoothly. The LTSS Maryland Help Desk is also available for any calls or tickets that need to be submitted for any system issues or any issues with speed in the system. We do recommend that you use the feedback tab in LTSS Maryland, as it allows both you and DDA to be able to track more easily to tickets that are submitted. Next slide, please.
And so this is a slide that's represent an at-a-glance visual of the EVV timeline that we've been working on. You'll see at the top right, we've got the dates highlighted for the regional office implementation approach, the October 1st, the November 1st, and December 1st. But also represented on this slide are additional actions and activities that we've been engaged in to support this effort. It includes our work related to ePrep that Ian shared, policies that we'll be issuing this week, regulations that we'll be finalizing, and various communications related to EVV, billing, OTP devices, and such. So at a glance, this gives you a sense of the different projects and activities we're doing to help to support the successful implementation of EVV. Next slide, please. So in summary, this is the action that's needed. Proactive, communicate, coordinate, and take action needed in order to support service needs of participants and families, and also to support the provider billing. Start looking at your personal supports data now to understand how many PCPs, health risk screening tools, and behavior plans, as applicable, your agency needs to review prior to your go-live date. Remember, it's important that we coordinate together so that we can get this in the system. DDA will be sharing the new PCP Detailed Service Authorization Tool, policies, and additional guidance this week. Reach out to each other. So CCSs reach out to providers, providers reach out to CCSs, and also the DDA contacts to coordinate that detailed service authorization process we talked about. For example, you could be sharing who's your designated contact staff in case there's any questions or concerns. Next slide, please. Immediately seek help when you're encountering challenges. As we mentioned, the DDA Regional Office Provider Relations Directors are available to help with any Medicaid provider number challenges. The LTSS Maryland Help Desk is available for system challenges, as Chioma just shared. The Regional Office CCS Squad is available to assist with any teen challenges. And again, the regional office will be conducting weekly calls to address concerns and challenges. The CCS agencies will be formalizing, if they haven't already, their formal strategy to distribute the OTPs to participants. Providers need to review and update in the provider portal any user roles as per Chioma's information she shared with us. Next slide, please. So this is just to remind us all that unity is strength. When there is teamwork and collaboration, wonderful things can be achieved. And as a person-centered system, as we look to support participants and providers and family members, we hope and appreciate your support in this effort to implement the EVV. Now we'll open it up to questions.
Thank you, Rhonda and Chioma, Ian, and Valerie, and Jesse. It looks like we have about almost 37 questions in the chat box, in the question box. So I'm going to start reading them, and I'm going to try to organize. I'll try to organize them in an order specific to EVV, and then specific to CCSs, and then specific to Valerie's slide, because she's got several questions on there. So I'm going to start with some of the OTP questions that it has. When clocking in with the OTP fob, do you need MA number or OTP code, or do you need both?
Hi, this is Jesse. I can answer that. So you will need two sets of information. So if the person is assigned an OTP token, then they will always need to enter in the 6-digit OTP number. However, the second component, you either need the 11-digit MA number or the 9-digit serial number on the back of the OTP. So those are the two sets of information that's needed. But this, and just to clarify, this only applies when the OTP device is assigned.
And Jesse, what happens if a participant loses or breaks their OTP fob, forget it at home, etc.? Do you log services until they get one?
Yep, that's correct. So in that case, I would please notify the CCS right away so that they can unassign that and make a note in the system. So then all the provider administrators who are in charge of billing would be the ones who would just enter these times manually into LTSS Maryland until a new device is taken.
Okay, and I have two that are taught together, and it's many of the individuals we support do not have landlines or have minutes based on their government-issued cell phones. It's not fair to equitable to ask the use their limited cell phones. Can the OTP be used for these individuals in lieu of their phone EVV? And then tied to that, there's another question that is it possible to combine the landline and OTP in a visit? For example, if the contact starts in the home but ends in the community, can the staff person use the landline to call it in at the start and then use the OTP at the end of the contact session?
All right. So to answer the first question, first it's, let's see, it was, hold on. Sorry.
Just having people use their own personal line when they have very limited access because they use government phones.
Yeah, so in cases where the participant does not have a reliable phone, which could in this case means if the DSP just isn't able to act, there isn't enough minutes or other things, then in that case we would recommend an OTP be assigned, and that OTP can be used, but the DSP would need access to another phone though. So, but that phone can belong to the DSP or just any other phone line. For the second question on if the phone call can start in the participant's home and then end in the community, the answer is yes. So in that case, during the clock in, if that is in the participant's home and you're using the participant's phone number, then LTSS will recognize who that person, where you're calling from based on the phone number, and you don't need that OTP 6-digit code. But then when you're clocking out and you're calling in from the community and the system you're calling from a phone number that the system doesn't recognize, then in that case, you do need to have that 6-digit code from the OTP device. So, but that can be combined.
And then I have like 4 of them that are combined about asking, the question is, how would they use the system if they're using remote supports, if they're doing virtual supports? How would people log in and out if they're doing virtual supports?
So as part of, this is Chioma, as part of Appendix K, there was the allowance for personal supports to be offered remotely. The current policy that is in place and will be finalized and shared, that is for the time being, why that is a current part of the service provision for personal supports. Provider admins or billing providers at the agency would then be responsible for manually entering the clock in, clock out for those remotely delivered personal support services.
What would be the lag time with replacing a device, and how is time recorded during that lag time?
So that time would be coordinated with the CCS. So it'll be dependent on how quickly the CCS would be able to get those devices out. But in the meantime, any clock in and clock outs that, since there is no OTP device, so they wouldn't be able to, those can be entered in manually into LTSS Maryland by the provider administrators. So in those cases, those times will be entered there and maybe need to be reviewed by MDH. But as long as the CCS, we see that the device is being, it needs to be replaced. And like there are many ways to track that in the system. We'll make sure that those payments, manual times gets processed timely.
What if the person cannot get in touch with the CCS, or the CCS is not responsive to getting this? Any other recommendations for that process?
So I think in the meantime, if those tokens aren't available, then if it's broken or lost, for example, then in that case, I would continue having the provider administrator entering those times manually into the system, and that way, like we have a way when we at MDH see all those manual times, we'll help coordinate with the CCS as well. So.
Okay, and now this comes to programs questions. Do we need to do a modified service request for service change to change from personal supports to personal supports enhanced?
So this is Rhonda. No, you would need to do the revised PCP in LTSS.
So should enhanced services be selected for everyone with a behavior plan or a health risk scoring tool of 4? Is any other approval from DDA needed for this prior to selecting the services in the system?
So it's a good question. No, the criteria as noted in our approved waiver programs are those 2 requirements. An approved behavior plan, so you want to make sure you've got a current approved behavior plan, or a health risk screening tool of 4 or higher. If those are entered and included in the PCP, then the regional office can immediately authorize that.
Do you need a new license for enhanced personal supports, or once you are licensed for personal supports, you are okay if your client is receiving personal supports?
It's another great question. And so the answer is, for personal supports, we certify providers. And so if you are certified as a personal support provider, you can provide both personal supports and personal supports enhanced.
Will EVV system also be used for individuals receiving ISS?
No, personal support services are the services that will be used for the EVV system.
Okay, this is a Jessie or Chioma question. For families or individuals without internet, what's the plan to get them information?
So for information that will be distributed to families and individuals, beyond the webinars that we mentioned, will be information in print. So letters or notices that will be going out to families and individuals around EVV.
And what is the backup plan to record services if the fob is lost or broken?
Sure. So I think Jessie supplied some information around that. It would be the same response here. Essentially, the provider admin or billing provider at the provider agency would be responsible for manually entering those dates of service.
Okay, Valerie, I have a question for you. We're assuming that the January 2021 payment will not include any advance. Is that correct? And when will all outstanding advances be due back to DDA?
So actually, the January payment would include an advance because it would include a win-loss and it would include an advance because we are concerned about the cash flow. As I noted in the slide, the reconciliation of all of this will take place through the cost report process after the year end closes.
Okay. What rate will be used after the go live date? LTSS rate or PCI's rate?
LTSS, Maryland.
Okay, this is for Chioma. Can the CCA's agencies attend the provider billing functionality? Except so if DSPs ask us questions, we can be prepared and tell them accurate information.
So a couple points of clarification there. For the provider billing training that will be happening online for provider agencies to learn how to use LTSS to submit billing activities, that training, due to the time frame and the fact that it is being delivered via webinar, will have a limited number of people on a daily basis. So with that, the recommendation is that CCS agencies are not taking up those slots, so we make sure to have enough provider staff trained appropriately. Additionally, CCS agencies' functionality around the training is completely different, around the system, I'm sorry, is completely different than what providers see. So the screen where providers are able to enter billing and make corrections to the system for the time that is clocked in or clocked out, CCS agencies do not have access to that and will never be able to see that part of the screen. For the training that is around general use of the system and webinars that will be distributed for DSPs, we would be happy to share those with CCS agencies as well to help contribute to communication or discussions or any questions that may come up.
Thank you. This is a Valerie question. CCS agencies cannot bill for mileage, so driving them to different individual homes will not be unbillable. Since we are directed to limit home visits and limit interactions, social distancing, etc., how does distribution going to look like with COVID limitations and restrictions?
So Patricia, I think we lost a little bit of the question.
So the first one is, it was about the mileage.
Right, so that is correct. The rates are fully loaded, so that means that there is not a separate payment for mileage. In terms of how the OTPs are distributed, CCS agencies, it is up to them in terms of figuring out what is the best way for them to distribute. They can be distributed through the mail, but I know more recently that has some of its own issues. It can be delivered in person, but I think it really depends on the situation, because again, in the during this public health emergency, we are all trying to limit in-person contact. So I think it will be up to the CCS agencies to decide what is the best approach to ensure delivery of the OTPs to the participants.
Thank you, Valerie. The DDA increased the manual entries per month per person for more than 6 times. This is for the manual entries.
Sure, I can provide some details there. So we did not currently, the manual entries in the system are capped at 6. However, as we've mentioned, due to the current public health emergency and some additional extenuating circumstances about how services are provided, Medicaid's ISAS team will be reviewing those closely and allowing some additional room where needed as providers adjust to this new system.
Chioma, are DSPs going to have to use 2 different time and attendance systems for clocking in and out? One for DDA funded personal supports and another system for private pay in-home supports not funded by DDA?
So as far as the DDA aspect is concerned, provider DSPs will have to use the ISAS system for clock in and clock out. If there are other services that are not DDA related, then that is up to a provider agency to manage according to their internal policies or processes.
If a provider agency declines the PCP, is the person discharged from the provider and the CCS proceeds to find another placement provider?
So this is Rhonda. I'll address that one. It's important that we communicate and coordinate. So if the provider is not interested at all in providing the services, then yes, they need to decline, let the CCS agency know that they choose not to continue or wish to provide personal supports if it's a new person in services, and then the CCS would then need to coordinate with the person to identify a new provider.
Okay. This one is a self-directed question. How does the EVV process work for people in self-directive services? Those individuals do not have a specific provider listed in LTSS. How does this affect billing for these individuals? Chioma?
So for people who are in self-directed, and Patricia, I'm not sure if you want to provide some additional details, but we are in the process of working that out. Currently, they would not be using the ISAS system as is, but at the point where there are additional details to be shared, then we'd be happy to provide that.
And usually all the billing will go through the FMS, so it would be the FMS using, but we'll provide additional guidance for people in self-directive services. Okay, those are the ones that I pulled before we went on, and after that I've got about another 20 extra that I'm going to have to read live from the screen. So when a DSP is providing general personal supports that are both in the home and in the community to meet the person-centered goals, will the key fob be used to clock in to a separate service?
So this is Rhonda. No, you would just clock in once, provide your services, whether it's in the home and in the community, and then once it's done, you will stop. If you have a breakage of services, a time in between where you're not providing services, then you would have clocked out and clocked back in. But if it's one continuous service, regardless if it's a combination of in-home supports and community supports, you would not clock in and clock out.
And after we responded to the question on Appendix K in virtual supports at EVV, I got additional questions on that. Again, people just want to know, how will Appendix K affect the implementation of the EVV due to virtual services? So Chioma, do you want to just repeat again your answer?
Yeah. So for people who are under the Appendix K, the Appendix K allows for virtual provision of personal support services. The current process, again, this will be outlined in the information that is shared. The current process would be that provider admin or billing provider roles at the provider agency are able to log into LTSS and enter the billing manually. So in the case that your DSP is performing providing services for someone remotely, you will be able to track to that via your DSP and communicate with them, obtain those hours, and bill them directly via manual entry into LTSS. There is a note that has to be indicated when that is entered. Again, all of this will be outlined in the information that is distributed to say that the service was provided remotely. And we will track to that and approve and process that in the ISAS system.
Thank you, Chioma. As a provider, we have not been contacted yet for the EVV trainer as a provider. Who should we contact to get this started?
Sure, that's a great question. We are finalizing training invitations that should be going out hopefully this week to all providers to register. Again, due to the timeline of the transition, 10-1 being the first transition that will cover Eastern and Western regions, we are targeting Eastern and Western regional providers to go first with training. We will be training from September all the way up to December, so it'll allow ample time for all 150 or so personal supports providers to be trained. But we will be targeting Eastern and Western regions first, starting in the middle of September. Invite should be going out shortly.
Will the detailed service authorization tool process require a PCPT meeting for each person?
That's a good question. The detailed service authorization tool is our strategy that can be help us to facilitate the plans being reviewed and completed. So that tool does not require a team meeting. As we put in the slides, the provider can complete. It would be shared with the CCS. The CCS would then review it with the participant to ensure that it's meeting their preferences and needs, and then have any dialogue with the provider with any follow-up questions, and then entry into the PCP detailed service authorization section.
If you already approve an ePrep, is that sufficient, or are you required to submit a separate application in ePrep just for personal supports?
So for ePrep, if you're approved in ePrep, you want to make sure that you have the approval and authorization for personal supports. If you have not applied to become a personal supports provider, you want to make sure you have completed that process and have that as part of your authorization.
Okay, and I think Joey answered this one, but I'm just going to read it one more time because it's been on this chat now 7 times. When a DSP is providing personal supports that are both in-home and in the community to meet the PCP goal, will the key fob be used to clock in and out, separate the services?
Yep, I can answer that again just to make sure. But so when an OTP token fob is assigned to a participant, and if the DSP is calling from using the participant's phone, then the OTP token will not be needed. However, if you're calling in from any other phones that does not belong to the participant, then the 6-digit randomly generated code from the OTP fob will be needed. So that definitely can look like where you start in the home and you call from participant's phone number, and then if you're taking the participants out into the community, then in that case call in from the DSP's own phone number to clock out. But during that clock out, you will need that OTP fob.
Jesse, there's another question here that you may be able to help with. Is individuals change their phone number frequently? How will LTSS Maryland keep up with the accurate data for individuals' phone number changing?
Yep. So in cases, if there's a situation where the phone number is constantly changing, then the OTP fob, the participant should have an OTP fob, and then the system will be able to handle that because the participant has an OTP fob, and you can call in from any phone number. But in cases where the phone number is changing, the CCS coordinator will be logging into LTSS Maryland and updating those phone numbers in the system. So just making sure that if as long as the CCS coordinator is keeping up to date the accurate information, then that'll be fine. But even if they don't, as long as they have an OTP token, then that won't be a big concern.
With the turnover ratio of the DSP Caribbean so high, and they have to change every 2 or 3 months, how long does it take to get this Social Security number changed within the new staff member?
It can be a couple of minutes. It will be the provider administrators themselves who will be logging into LTS Maryland to update that information. It only takes a couple of minutes to do. So as soon as they get that in, that staff's information will be ready.
How will the process be different for new individuals beginning services during this transition? Will they start first in LTSS or placed in PCS2 until providers go live date?
So that's a great question. As far as the LTSS portion, for someone who is coming in new into services, into personal supports, that should be updated in their PCP which will go through the process of being accepted by a provider and then subsequently approved by the regional offices. If there are additional services beyond personal supports that are not live yet, then those would be authorized in PCIS2 as well.
Hey, Jesse, this was for you. What about HIPAA violations of everyone knowing an individual's MA number?
Yeah. So that just knowing the MA number by itself, that would, since that's the only piece of information entered in, then that wouldn't be a concern. But if the participant doesn't feel comfortable with sharing that MA number, then they can use the 9-digit serial number that from the OTP device. So that's an alternative.
Okay. Most of our clients leave our facility and they go out in the community and stay there until they go home, and there are no phone services. What then? In other words, there is no phone to use other than the DSP's phone. So I guess the question is, can they use a direct care staff phone if they're not near a phone line to call that's been identified with the device?
Yeah, so as long as there's an OTP device issued to the participant, then the DSP can call in from any phone number. It will be easier if they call in from a phone number that belongs to the participant, because then they don't have to enter in any of the participant's information. But in cases where as long as they have the OTP token, they can call in from any phone number.
Thank you. People want to know, could they have the questions and answers printed for the future? As you heard down at the beginning, this webcast is being recorded, and then we'll upload it into our website and send the link to all the people that register so that you could hear the answers again. Because we're reading every question. How does the CCS request a new device?
So the CCSs will receive like a bulk shipment of these. So they'll have a couple hundred devices. So if it's talking about getting the new individual devices, then they'll have to coordinate within their CCS agency. If the question is referring to getting a new shipment, then they can contact the MDH ISAS team. I believe that information will be part of the CCS guide. So they would just the CCS would just need to send an email to us, and then we'll make sure that they'll get a new shipment of more tokens.
So Jesse, you mean, so really in essence, in my understanding from Chioma is that a CCS agency is going to get a lump sum of devices so they can distribute at any given time. And when they're running low, they need to let us know so that they can have a backup in their agency. Is that correct?
Yeah, that's exactly right.
Thank you. Okay, I'm just going back. I'm just reading now through this chat box just to be sure that can there be more than one administrator?
Yes, there can be multiple provider admin users at an agency.
Okay. Some are repetitious. I'm just going through. Rhonda, can you go in there and just see if there's anything, or Chioma, that I don't want to miss, that I did not repeat it already. Does the state of Maryland have any parameters surrounding manual edits? For instance, is there a certain percentage of manual edits that will lead the questioning for an audit or withholding of reimbursement?
Jesse, do you want to respond to that as to current Medicaid policy?
Right. So in terms of manual entries, so we're talking about this is more for like under normal circumstances. I mean, it'll be a little bit different while we're doing throughout the transition, but the limit will be it's 6 times per month per DSP. So anything beyond that would payment will be impacted for those. But I mean, there may be a change in policy, at least for the initial rollout.
Yeah, and we've gotten this one asked 4 times, where there be a change to the 6 months limitation. Can you have a dual role in LTSS? For example, can you be a program staff and be a DSP?
Yes, you can be a program staff and be a DSP in the system. If that is something that occurs sparingly for your DSP role in the system, you may have to check in on your login, logouts abilities into provider portal. But at any time, the admin provider agency leadership is able to update that. So if you do have program staff that also assist with being DSPs on occasion, or maybe do that pretty often, you would be able to set them up accordingly.
Okay, thank you. This is a Rhonda question. Is transportation included in all personal supports and or just enhanced?
It's a good question. Personal supports and personal supports enhanced includes transportation under the new rates that will be billed through EVV.
Okay, this is a Chioma question. Currently, only 27% of the individuals that we serve under personal supports are visible to us in LTSS. How will providers bill for individuals that we are unable to access an LTSS?
So that's a good question. If an individual is not currently listed on your client list, or what you may call a client roster, it means that you currently do not have an approved PCP for them in the system. If you've either accepted services, or CCS is still working with submitting those services, or it's been submitted to the region and has not yet been approved, that individual will not show up on your list as a provider agency until there is an approved and authorized PCP listing you as a provider in the system. So over the next number of months, as Rhonda presented with and Ian with the PCP tracker list, we will be tracking to those efforts to make sure that everyone in personal supports accurately has the provider who's going to provide that service and an approved PCP in the system before the respective go-live date.
Thank you. Valerie, I have 2 questions for you. I'll start with the one about LTSS. Are the LTSS personal support rates final? Where can we find them?
So DDA has been working with the rate setting technical work group. We've had 2 recent meetings, and we are close to finalizing those rates. Once they are finalized, we will A, publish them, and B, they will be in LTSS.
Thank you. This one is about, are the CCS's new responsibilities and activities in this process billable activities?
I'm not sure. Without additional detail, I think it's difficult to answer that question accurately.
Okay. All right, so this person, if you could send Valerie an email with that question, we'll be happy to provide additional information. So we have about 11 questions about people in self-direction. Does this apply to people in self-directions? When will they bill? Are they going to get the training, the rates? When the self-directed service begin in EVV? Valerie, do you want to talk about that? Or would you like me to?
Oh. Well, I will certainly start, and Patricia, would certainly welcome any additional comments. So as I think this question was similar to a question that was asked earlier in terms of people in self-directed will not be using ISAS, but rather when we finalize the selection of a vendor to provide FMS services, they will be responsible for setting up an EVV solution for people in self-direction.
No, that's correct.
Yep.
There is a couple here more with about 15 more came in. Currently, demographic information is not able to be saved. Moving forward, will LTSS Maryland now allow us to enter and save new phone numbers for the persons that we support? Chioma.
Currently, you should be able to enter and save phone numbers. If there is a specific issue with that, please submit a ticket. But we will be working to update some of the other parts of this, the demographics for an individual in the system to allow CCS agencies potentially to be able to edit some of that and make changes.
Okay. Chioma, what should providers do when there's an issue with billing units and the provider and the CCS have worked together to fix it, but it's still not fixed and the LTSS help desk has not responded?
If you can share that ticket with a DDA service desk, including the ticket number from the LTSS help desk.
Okay, thank you. For the detailed service authorization updates, we will need to make, will the new PCP signature page be needed?
At any time when there is a change to someone's services in the system, whether that is the units, the service time period, when it becomes effective, or provider, there is a requirement to sign off on a signature page electronically in the system. So all of that should be done through the service referral request process. It goes to the provider, where the provider can accept that directly in LTSS and have that provider signature page rendered as a PDF.
Okay. If the provider administrator has to enter the time in and out in LTSS for the DSP, does it have to be done on the day of service itself?
That's a good question. No, it does not. You do have a little bit of time to be able to enter that if there's a missed clock in or clock out, or a remote service that was delivered that needs to be manually entered. There is a general timeline for when the month's requirements are to be submitted. For example, for the month of July, there's a date, I believe, in the first week of August when that is due, or for the month of August, and it's due in the subsequent month. But with regards to the details around that, that'll be included in the policy that is distributed, and what the timeline for completing those kind of entries are.
Okay, this one it's a simple question, but it has lots of answers to it. So if a support staff is working with an individual and that individual has to go to dialysis and the staff accompanies that to the clinic, does the staff have to clock out during the time that the individual is on dialysis?
So this is Rhonda. If the personal support staff is not providing services during that time, then yes, they would clock out while the person is receiving the dialysis.
Okay. How does this affect people who refuses to allow us to provide services but doesn't want to leave the agency, and how would we document this?
If a person is refusing the services, then you would note that in your file and no services would be rendered.
Bill for, yeah.
Right.
In LTSS, can you confirm you can only either register a phone number or a OTP?
So in LTSS, a person's phone number would already be listed. And so if that's the way that the DSP is calling, that would register the clock in or clock out. The person could also be provided an OTP that could be used when they're in the community, which was the example that Jesse shared. Both of those would be noted within LTSS and registered.
Okay, the next one is either could be Rhonda or Ian, or if the current approved PCP already aligns with the service authorization tool provided by the personal supports provider, is the CCS still required to revise the plan?
So that's a good question. If it currently reflects the correct service units and the provider has accepted it, then there would be no action needed. It would be true and accurate.
Okay. E-prep authorization for personal supports as a provider. How can you confirm as provider this part was completed? Who could the provider contact? Great question. Each region has a provider relations person, and they can tell you whether it's been completed and you have a base number. If you already have your base number, you've got an email from ePrep, that should be good. But if you have any doubts or questions, you can contact your provider relations. Chioma, do you want to add anything to that?
Sure. So in the provider portal, if you are currently able to log into the provider portal as you have that set up, you can see on if you click into the provider tab and open that specific location, you can see all the services authorized for that location. So you'd be able to confirm if personal supports is supposed to be listed there, that it is listed there, or other services. If you find something that you believe you applied for, or there's a mistake and it's missing, please follow up, as Patricia mentioned, with provider relations so that we can confirm what needs to be there and what should not.
So it is now 3:31, 32. Sorry, I missed the time here. There's about 8 more questions in this chat box, and some are repetitious. But one, I can tell that people don't understand this very clearly, so I have to read this one, Chioma. When there are 3 individuals in the same home, will it require 3 separate clocks in?
So it is, as personal supports is defined, it is a one-to-one service. So one DSP serving one individual. If you're referring to, that question is referring to one DSP serving 3 individuals in that home, then that is not personal supports. So if you are just coming to the home to serve the one person, even though they live with 2 other people, then you would be clocking in for serving that one person and clocking out when you're done serving that one person. You should not be serving 3 people under personal supports as it is currently defined.
Yes, and then people want us to revisit the answer about the dialysis. And again, that's based on the definition. That's why I said it's based on how people interpret the definition of personal supports and what it is. Based on some of these questions, we may need to go back and do some training about what is personal supports and how is it used and when is it used. All right, it is now 3:33. I know we had you guys from 2 to 3:30. So really do appreciate it. If you have any specific questions, please go to the slide that tells you where to go to for questions and answers. If you have a specific question about today's webinar, anything related to EVV and the devices, Jesse would be a great person. Anything about the LTSS Maryland system would be Chioma. Program specific, Rhonda or myself. Anything with payment, billing would be Valerie. So I thank you all and have a great day.